So hi everyone, thank you very much for watching Distal Bypass Competition 2022. Distal Bypass field is now very exciting because of best CLI results. So I'm Nobuyoshi Azuma, vascular surgeon from Asahikawa, Japan, and moderating this international event with Professor Palma Shaw representing SVS and Professor Marit Venermo representing ESVS. So I'd like to explain today's event using slides. So please slide. Thank you. Today, 4 finalists will do a live demonstration for aiming a gold medal. Before this final game, there were 5 candidates from SVS, 5 candidates from ESVS, and 16 candidates from JSVS. So their recorded video were evaluated by judges on each site. And then we had several meetings. Then 4 finalists have been selected. So I would like to introduce our finalists. Dr. Yuki Kinoshita from Tokyo Medical University, Dr. Amanda Kistler from Albany Medical Center, Dr. Ika Jelvien from University of Helsinki, and Dr. Yohei Ichikawa from Kyorin University School of Medicine. This slide shows that the steering member of this final game, 3 moderators, 5 commentators, and 5 judges. All members have contributed a great deal of time and effort to this event. We are very happy to work with such world-famous vascular surgeons. This slide shows the moderators and commentators. Please give us your comment and self-introduction. Professor Shaw, please.
I'm Dr. Palma Shaw. I'm a professor of surgery at SUNY Upstate Medical University and the Secretary General for the World Federation of Vascular Societies.
Thank you. Professor Venermo.
Hello, everybody. I'm Marit Venermo. I'm from Helsinki University Hospital, professor of vascular surgery, and currently the Secretary General of European Society for Vascular Surgery. It's great to be here. Thank you for the invitation.
Thank you. So I would like to introduce the commentators. Professor Darling-Hatt, please. Could you give us a comment on the self-introduction?
Clem Darling from Albany, New York. I'm past president of the SVS, and I'm very excited to be here. And you did a wonderful introduction, and I want to commend all of you for helping out.
Thank you. Professor Komai.
Hi, everybody. I'm Dr. Komai from Kansai Medical University Medical Center in Osaka. I'm just assigned as a international chief of international committee of JSVS and council of WFVS. Thank you.
Thank you. Professor Obara.
Hi, I'm Hideaki Obara from the Keio University, Tokyo, Japan. So it's my great pleasure to be here and like to enjoy the young surgeon's great procedure. Thank you.
Thank you. And then, unfortunately, Dr. Kazuhisa Sakamoto has an emergency operation. He cannot make it today. So I would like to introduce Dr. Peter. Peter is representing a young vascular surgeon.
Yes, thank you for a kind introduction. My name is Petar Zlatanovic. I come from Serbia, Belgrade in Europe, and I'm currently working over there and acting as a secretary of the trainees from the European Society for Vascular Surgery, and it's a great pleasure to be here. Thank you for a kind invitation.
Thank you. So this slide shows our judges for final round, and I think I would like to ask judges' comment after completing 4 finalist procedures. So and then please wait a little bit. So judging process is very important for this event. So we did we use lots of time to standardize the evaluation, and we did some practice. So thank you very much for judges for your great contribution. This is a preliminary judges and faculties for preliminary round. So many vascular surgeons are contributing to this event. Thank you. Next slide, please. Yeah. So many vascular surgeons did a lot of work. Thank you. This slide shows that evaluation seat. We are using ice skating method in this final round. So and then, which means that the audience will promptly see the score for each procedure. The total score is composed by 3 components: the technical point, composite point, and the deduction. Also omitted from this slide, detailed determine criteria and appended to each evaluation. Next slide, please. So this distal bypass competition organized by JSVS, collaborated with SVS and ESVS. So mission task force by EBM Corporation. I think it must be very difficult to connect many places in the world with a very high resolution image. Dr. Park, could you give us comment?
Yes, thank you, Dr. Azuma, and hello, everybody. So now I'm broadcasting, doing live streaming from Fukushima, Japan. Maybe you know the name Fukushima. Actually, after disasters, we are now currently on the way of the regeneration. And now, so this is my great pleasure to do live streaming here from Fukushima. So please, everybody, please enjoy. And thank you, Dr. Azuma, and thank you, honorable judges, and thank you, faculties.
Yeah, but it looks very complex. Thank you. So, and sponsored by Johnson & Johnson, Japan Gore, and Lemeto. Next slide, please. So I would like to introduce a little bit short history of distal bypass competition. So JSVS has started distal bypass workshop since 2013. At that timing, that the distal bypass in our country, annual number of distal bypass are not increasing, maybe decreasing. So that's why JSVS decided to start this workshop. Next slide, please. And also, many Asian countries have been losing vascular surgeon can do a distal bypass. Also, the teacher of the distal bypass. So we decided to do a first distal bypass workshop in Asia. And then we want to continue this event, but we encountered the pandemic. Then last year, distal bypass competition 2021, the first competition during ASVS meeting, we challenged this event. Next slide, please. So the junior class live competition, Dr. Conte and Obara Komai and Dr. Kim joined us, and then senior class, Dr. Oki, Dr. Khan, Dr. Lang, me, and Fujimura did collaborating. Then this time, second distal bypass competition, now approaching a final game. Next slide, please. Today, I think please enjoy and become familiar with distal bypass procedure by watching this event. Also, please also enjoy not only surgical skill, but also mindset and important concept as a vascular surgeon. Hopefully, this event will become more important in the era after best CRI. So now maybe setting of the first finalist. Now ready?
I am Yuki Kinoshita, a fellow of cardiovascular surgery of Tokyo Medical University from Japan. I'm so happy and excited to join such a great competition as a finalist and as a representation from Japan. Look forward to showing my anastomosis to you guys, the experts of vascular surgery in the world. And I'd like to get a lot of comments and advice from you guys. And I want to use this awesome opportunity to make my anastomosis better. I'm here to get a gold medal today. I enjoy this competition and I believe I can make it. Thank you.
I'm Hitochi Ogino, a professor and the chairman of cardiovascular surgery, Tokyo Medical University. This time, my colleague, Dr. Kinoshita, has challenged the distal bypass Olympic game. So actually, he has great surgical skills as well as a lot of knowledge of vascular surgery. In addition, he has a strong desire to excel as a vascular surgeon. I hope he will get a gold medal and become a great vascular surgeon on a global scale in his future. Thank you very much for giving him a good chance.
Okay, please start your procedure, Dr. Aki.
Yes.
Yeah.
So yes, I'm doing now.
So I would like to ask about your adequate shape of trimming of the vein graft. Commentator Dr. Darling. So what do you keep in mind when trimming the vein graft?
Well, usually when you are make the arteriotomy first and then size the graft to that, we found it easier just to take the forceps and use an 11 blade to cut it instead of using the pots to cut down, so you can decrease the wings, so you don't have to cut back the wings, which is always a little bit awkward. But
thank you. Yeah. So how about Professor Benelmo? So that the trimming of the vein graft, shaping a vein graft.
I usually cut the vein as oblique manner and then extend the heel. And it can be a little bit too long, but it cannot be too short.
I see.
Very good point.
So how about your Dr. Komai?
Yes, the same as others, but I think it would be better to cut the artery first, and then just check the length, and then we will trim the veins, so that they are just adapted right way.
I see. So Dr. Obara, so I would like to ask you about your length of the size of the arteriotomy.
Okay, thank you for asking me. So it's totally up to the size of the artery and whether the artery has the calcified lesion or not. So, but basically, I try to put the incision around 1.2 centimeter to the 1.5. Maybe the 2 centimeter should be a little bit large. So I would say that 1.2 or 3 centimeter should be better for all.
It depends on the vein graft size or not.
The first reader, my procedure is the same as Dr. Komai. And firstly, I try to put the incision on the artery, and after that, I cut vein graft, like oblique size, and then I make the little bit of cup shape, especially for the toe side.
Oh, by the way, that scoring is okay, Dr. Park?
Yes, about arteriotomy, still I'm waiting for Dr. Zhou and Dr. Conte. Please add score of the arteriotomy, please.
This time, score arteriotomy, including adequate or not a vein graft trimming, also include the score of this segment.
Yes, and this score is out of 10, so full score is a 10. Okay, 0 to 10. So we're still waiting for Dr. Zhou, please. Arteriotomy.
Professor Shao, how about your opinion regarding size of the arteriotomy?
Yes, I gauge it based upon the diameter of the vein graft that we have available, generally 1.2 to 2 times the size of that.
I see. So how about Dr. Darling, sir? Same question.
I agree. I usually do about 1.5 times the vein size. Obviously, sometimes it depends on the angulation that it comes in on where you're going to do your distal. But
so, what do you think about the parachute technique for this finalists are using? Parachute technique?
I think he's doing a good job with it. The only technical thing you always worry about is you never want to grab the proline suture with your forceps because it can fracture it. But
I see.
But the parachute technique, it helps with seeing the heel and the toe as you're doing the anastomosis. When you tie it down, sometimes that limits you, but obviously the good results of both.
So, how about your Professor Benelmo? what do you think about your parachute technique?
And the parachute technique of this compositor, it's beautiful, very gentle with forceps regarding the vein and artery. I also noticed that he took with forceps from the suture that is sort of forbidden in our hospital. Because it may cause fractures in the long run, maybe cut the suture.
Yeah, it's an important point. So my young colleague also sometimes, doing the same thing. So I always make caution, but so that how about the score? Dr. Park, is that all right?
Still requesting heel score, Dr. Conte and Dr. Kodama. Please double check the heel score, please.
Can I talk during the procedure?
Yeah, please.
Okay.
Who?
Usually I leave the needle. I mean, I don't hold the needle with both hands at the same time because it can be add the pressure to the artery.
Oh, could you say again? I cannot hear. Hold what?
I don't hold the needle at the same time with both hands.
So
like I did, I leave the needle.
So what do you think about this point, Dr. Benelmo?
You mean touching with the forceps and with the needle holder at the same time on the needle?
Yes, exactly.
Yeah, well, we try to avoid touching the needle forceps, but sometimes you have to, of course, do it, but try to do it so that you push, pull with the needle holder. But yeah.
The only other comment right now, I think you would need to make a little bit bigger arteriotomy to fit the vein graft in.
That's right.
Yes, I usually adjust before the talk. So I will add arteriotomy more.
So how about the score with the arteriotomy and heel? Dr. Park already score.
Yeah, still requesting initial side. So Dr. Konka, Dr. Zhou, Dr. Hoshina, please give a score. Initial side, please.
So Dr. Darling, you commented the size mismatch, right? So when you feel size mismatching, you are doing the extender arteriotomy or cutting a vein graft or other.
It's usually easier to extend the arteriotomy than to
right.
vein, because what happens is you may not get the right kind of arrowhead at the
That's right.
So we usually like to extend the arteriotomy. You know, part of that depends on how diseased the distal portion.
That's right.
Yes, exactly.
But hopefully you've picked a good segment of vessel to go to.
Right now, requesting initial side score, please.
So Professor Shao, what do you keep in mind when you are suturing the toe side. Palma.
The stitch is the apex.
So toe side. What do you keep in mind when you are suturing the toe side? Toe.
Are you asking for me?
Dr. Shao. Palma.
Okay, okay.
Yes, yeah, I would admittedly, I have to admit that I use the anchor technique in my distal bypasses, although I think it's just a matter of training. And I start heel to mid anastomosis, and then I do tip to mid anastomosis. And I always make sure I can see well within the lumen, particularly at the tip and the heel. And sometimes I'll even put a big stylator in to really ensure, because sometimes with the calcium that's present, it can be difficult to ensure that you're truly in the absolute true lumen.
Dr. Komai, how about you? Regarding or suturing the toe?
Yes. It is very important to check the inside, intimate side of the artery, of course. So I tend to push the vein to the opposite side so that you can see the whole of the artery, and easier to put the suture in the inside of the artery.
So now maybe need a score with the toe. Dr. Park, is all right?
Yep. Still requesting the toe scores. Yeah, accepting. Yep. Dr. Zhou, Dr. Conte, please check.
I think a first competitor, procedure, what can I say? First competitor is very difficult, and then but maybe he feels some tense and pressure because
Actually, I'm enjoying.
Oh, really?
Yeah.
Yeah, because of world famous vascular surgeons are watching you.
Yes, that's why I enjoy.
Oh, that's good.
Okay, toe score.
Very standardized. I mean that the score, the difference between the judges are very small.
Thanks so much.
And then could you cut the graph and show us that the inside of the anastomosis?
Sure.
This is only we can do this simulation, not in clinical, but it's important.
Okay, now requesting the other side, number 5, the other side, please, judges.
There you go.
Mm-hmm.
Can you see that?
Yeah, but a little bit more toe side. Thank you. Mm-hmm. Yeah.
Okay, judges, please put the score on the composition point, please. Composition section also. Dr. Zhou, please check the other side and not type, please.
I prefer the needle, the Proline from HCO, and the product number is 1757. It's the curve of needle is weaker compared to 175.6. So I want to use the needle more like straight. So I prefer this needle.
The other side.
It means it's this needle provided by us is not little bit different from the needle you are using in clinical. You mean?
Yes, in clinical, yes.
So thank you very much. Your fight. Good fight, Dr. Yuki. So please wait and watching other three finalists.
Yes.
Yeah. Thank you. Thank you for your video also. Then I think next Dr.
Dr. Azuma, still, please check the score now. Technical points.
Okay.
Yeah, technical points and details. Technical points. 44.67. Arteriotomy 6.6. Heel 7. Initial side 6.6. Toe 7. The other side 8. Nut tie 9.3. Total 44.6.
So how about the composition point? Oh, here.
Composition points 31.5. Deduction 1.33. Total point 74.83.
So what is for the deduction? I mean, the reason of the deduction, you can tell us, or difficult? Can you, deduction point, reason of the deduction?
Okay, point change. So total point now 75.5. This is details.
Okay. So I think, yeah. Thank you very much. So now next competitor will beat this score or not. So for next competitor, Professor Parma Shaw will moderate. Please.
It's a pleasure. Yes, thank you. So I'd like to introduce our second finalist, Dr. Amanda Kistler, who's training under Dr. Clem Darling at Albany Medical Center in Albany, New York, my neighbor.
Oh.
Hello, my name is Iikka Järvinen. I'm a fifth-year vascular surgery resident at the University of Helsinki Hospital. I'm honored to participate in this year's bypass Olympic Games. Thank you.
Dr. Park.
Dr. Park.
Yes.
This is not Amanda. Dr. Amanda's video.
Yes. Okay. All right.
Yeah.
Yep.
Thank you.
Hello, my name is Amanda Kistler, and I'm a fifth-year surgery resident and chief vascular surgery resident at Albany Medical Center. Albany Medical Center is located in Albany, New York, and is a level 1 trauma center and tertiary referral center. I, however, am not a New York native, and am actually from a small town in Northeast Ohio called Lordstown. While completing my training at Albany thus far, I have completed nearly 450 open peripheral revascularizations.
Congratulations on advancing to the finals. We're very proud of you and we know you're going to do great. Good luck, Amanda. You're the best.
Congratulations for your SCF representative. I know you're going to do a great job.
Luck in your anastomosis competition. Amanda, good luck in your anastomosis competition.
Good luck.
Good luck, Mo.
Congratulations, Mo, and good luck.
Congratulations, Modi.
We believe in you. You are so proud of you.
You're the best.
You got this, Aunt Kuka.
Go, Modi.
Go, Mori.
Regarding the arteriotomy and vein trimming, would any of the commentators like to comment? Potentially Dr. Komai, can you comment?
Actually, the picture itself is not so good, so I can't comment on that. I think the procedure itself is not so bad, but I don't see the detail.
I agree. Dr. Park, are you able to improve the clarity of the image?
Oh, this is the maximum. Yeah, this is maximum. It's a dependent network of the US side issues. So we did the rehearsal and stuff. Actually, this is much better. It's better than rehearsal. Yeah.
Okay, I understand. She initiated this time within the arteriotomy and then trimming the vein. Dr. Obarak, are you able to make comments? Potentially how you...
Thank you for the question. So I prefer to use the scissors to cut the vein graft like her. So I think it's a fine technique. So, but unfortunately, the focus is a little bit out of focus. So it's kind of difficult to say something clearly. Thank you.
Okay, Dr. Zoe, Dr. Conte, please score of the arteriotomy, please.
It's a little bit off screen. I don't know if this can be adjusted so we can see her technique better.
Arteriotomy score. average 8.
I'd like to ask Dr. Zlatanovic to comment potentially as a trainee regarding their approach, parachuting versus anchoring approach to these anastomoses.
Thank you, Dr. Shah. That's a very good question. So in a center where I work, we are always trained to do parachute technique. So yeah, we seldomly use anchor technique only for very small vessels, but still that is very, very seldom as mentioned. But what I can notice in her anastomosis, and what I like is that she started doing a bit from the outside. Now she's doing from the inside. So in comparison to the previous competitor, she's doing it from the both sides. That's in my opinion how we are trained in the center where I work. Also, as a small tip, I noticed that the competitors are a bit of struggling with a vane when they're doing a parachute. What we kind of like to do is put a small pan and take a part of the adventitia of the vein and just stick it to subcutaneous tissue so that we can, have it like in the ear while doing the anastomosis. Yeah.
Okay, thank you. And Dr. Sakamoto, was he available, to comment regarding how many throws prior to pulling down the parachute are taken? Is there a difference or true preference?
Dr. Shao, so sorry, Dr. Sakamoto is now emergency operation, so he cannot make here. Yeah.
Well, perhaps Dr. Komai can comment regarding the parachute technique and how many throws on each side prior to pulling down.
Actually, it depends, but usually 5-6 stitches. And if it is too many, you can the string might be struggled. So I think the fewer the better, but it depends.
Can any, with respect to the heel, could Dr. Komai maybe make a comment regarding the heel technique here?
About the heel?
Yes, the heel she's creating, if you can see that.
I think you can, we usually start from the far side and then put the stitches to the nearest side for 5 or 6 stitches. So I think the starting with in the middle is a little bit difficult for us. We just go around the heel.
Dr. Darling, is it in your practice, is it typical to start directly at the heel or do you vary that in your institution?
No, we always start at the heel, go anterior about 3 or 4 bites, and then go underneath and end up on top on the anterior surface, which we think is the easiest. So we try to get the harder side done first. When I was training in Boston, my general surgery, like you, Palma, we did the quartile technique, which works well. But when I came to Albany, I changed over to the parachute technique. And one of the things we do differently than most, I think, is we don't put a U-stitch in the heel. Usually we just have a transition stitch where 2 stitches are close to each other. So you can reverse the needle, as was stated before.
Dr. Park, are we due for any scoring?
Yep. Now, initial requested score, Dr. Zhou, Dr. Conte, Dr. Hoshina, please recheck the score of the initial side, please.
So she's moved to the toe, initiating that approach. Dr. Obara, will you be able to comment?
Yeah, so let me double check. So did she put a state suture on the toe side, like a U shape, or just one stitch? Parma, can you check that?
I think it was hard to see.
Yeah, it's kind of hard to see.
Dr. Darling, are you able to answer that, his question? Maybe. The toe is also being parachuted as well here.
The toe is also parachute?
I'm asking because I didn't appreciate
Okay, so it's kind of difficult.
Sorry, Paloma, can you hear me now? I was kind of
Yes.
taking.
Yeah.
Yeah, we don't usually put a U stitch in. We usually, as I mentioned, on the heel was where we reverse the stitches so we can go outside in on both anterior and posterior. So at the toe, we do not put a U stitch in. It's just this over, baseball stitch, I guess, for lack of a better term, which everts the anastomosis.
And then at the toe, there was a little lack of clarity on the screen.
Yeah, the toe, it's just continuous. It's continuous outside in, outside on the vein, inside on the artery.
Okay.
No U stitch.
Okay. Thank you for clarifying.
Sure. My computer skills, as you know, are somewhat limited here, so I'm trying to.
Yes.
And I apologize. In Albany, we don't have very good cameras, so maybe that's what.
You need a Japanese camera. Dr. Zlatanovic, can you comment on her knot tying, please?
Well, as far as I can notice here from the camera, also she's doing it good. The way we are taught as a trainees, again, the center where I work, is to tie it, so let's say around when the anastomosis, there is not roughly 10 to 12 times, but each time you tie the knot, you change the kind of like technique. You either do it with your middle finger or with your index, so like it secures the knot. Also, some surgeons are using I don't know how it's called, it's like a sailor knot. Where you like double cross a double and just put it down, and this secures the knot and the anastomosis. But yeah, I think it's good in her case.
Dr. Venermo, would you like to make any comments regarding the techniques?
Thank you, Dr. Shaw, for asking. The image is a little bit blurry, but as I noticed, it was very good. I think that the toe was a little bit sharp from Ravino's side, and it was really not very easy to see really the place of the stitches, as the image is a little bit blurry, but good to my eyes.
I would agree with you. At the tip, I usually don't have a very pointy tip to the vein. I usually blunt that, so it's a little bit squared off. And I did not appreciate well her technique right at the tip, I think, due to the resolution. Dr. Park, are we doing well with respect to the scoring for other side or not time?
Okay, now the other side's ready. The other side, 7.5888, average 7.83.
And then just the knot tie.
Yep. Dr. Conte, please check the knot tie score.
And do we have the time, the duration of the anastomosis time frame? Any other additional comments that any of the commentators or moderators would like to make while we're waiting for the remaining scores?
Technical point 8, 7.3, 7.1, 6.8, 7.8, not tie 9. Total 46.17.
Dr. Zuma, would you like to make any comments?
Thank you, Dr. Shao. So I also would like to point out that the shape of the vein graft, the toe is a little bit too sharp, so maybe losing a patch effect. So yeah, but I'm not sure, but maybe toe a little bit too sharp, I think. But she is very unfortunate to regarding the resolution of the image. So we tried to that the staff tried to make making better, but unfortunately somehow it's not. On the timing of the rehearsal, her image is very clear, but now today is not good. So, very sorry about that. Thank you.
Dr. Park, do you have the time, the duration for the anastomosis?
All right, so asking Yuki. So Yuki, you're keeping time?
$12:39.
Hmm.
Okay. And do you have any of the composition points completed or the deductions to reveal? Thank you. She did a very nice job. If there's no other comments, I think we can move on to the third competitor. Dr. Venermo, you can take over.
Yeah, thank you very much. So it's a really great pleasure to introduce the third competitor, and he's Iikka Järvinen, trainee of vascular surgery in Helsinki University Hospital. And she has been training in our hospital for 2 years and 1 more to go before graduating vascular surgery.
Hello, my name is Iikka Järvinen. I'm a 5th-year vascular surgery resident at the University of Helsinki Hospital. I'm honored to participate in this year's Distal Bypass Olympic Games. Thank you for having me.
Mä sanoin hiipää. Kiinnitin siihen huomioon. Okay, Dr. Järvinen, you can start the anastomosis. Dr. Asuma, any comments on the arteriotomy and cutting the vein?
I think the vein shape of the trimming is I think adequate. Also the size of the arteriotomy, for me, a little bit small or but size is matching, or arteriotomy is a little bit small. I'm not sure, but yeah, that's shape of the vein is very good.
Thank you. I would like to ask Dr. Darling how you keep the vein during the making the heel part. You are muted. I'm sorry. I cannot hear you.
Thank you. It's great seeing you again, by the way. And usually we try not to put the forceps in there too much just because we worry about damaging the intima, but sometimes we'll leave what we call a handle on the toe to hold the vein up so you can adequately see the heel of the anastomosis. It's hard to do, I think, with the material we have here. So but I think that he's doing a very nice job of being meticulous about suture placement. But the only critique would be that we try not to put the forceps in there or use the forceps that touch the intima and just touch the hold on to the adventitia.
Thank you.
Okay, now requesting the arteriotomy score, please. Dr. Zoe, Dr. Conte, please check the arteriotomy score.
Dr. Komai, I would like to ask you how you practice rotating the needle during the anastomosis with your trainees.
I usually tell the trainees that you shouldn't put the needle inside the artery, but on the other hand, it is very important to see the inside of the artery or vein when you put the suture. So sometimes I actually put the forceps inside the vein to open it, as he's doing. So I like this technique.
Thank you. Dr. Zlatanovic, would you like to comment the heel part?
Yeah, thank you, Marit. So yeah, I think he's doing it very nicely. Although it's not an easy job, I mean, to do it on your own, usually have an assistant who's holding you the vein. Yeah, I would like just to add as maybe a small comment for as Dr. Komai mentioned, to open the arteriotomy. What we sometimes do, I think it's quite useful. we put like some staying sutures from the both sides in that manner from the inside of the artery, and it opens up. So it makes it sometimes easier when the artery is quite small.
You mentioned that this may be more challenging to do without assist. I think also that you have to handle the sutures without somebody keeping them. It's challenging for.
Yeah, I can see how actually all the participants are struggling, you know, in order not to make to create a knot while they have to you know, to take care about this, and it makes it quite difficult. But regarding the rotating of the needle that someone mentioned, I think it was also Dr. Komai, what we residents are told in my institution is not to lock the needle holder when you're like holding the needle. In that manner, you
Heel average 8 point.
And what I can notice, maybe Marit is not using the Castrevejo needle holder. So is that maybe common in your institution? So you're teaching the residents in these small anastomosis not to use pen holders?
Yeah.
Yeah.
It's really great to see different cultures, and one thing we keep quite important is that we try not to touch with forceps on the needle so many times. Of course, it's only the question of flow. It's not sort of dangerous. Would you like to comment this point, Azuma?
Please give me a question again. forceps and I'm sorry, I cannot hear.
Using forceps to draw the needle outside the artery or vein.
Mm-hmm.
I see different cultures as we practice it not to touch so much the needle with forceps.
Aha, I see.
Use needle holder to handle the.
You mean that we do a better. We had better to use a needle holder, not the forceps.
Do you pay attention into this part?
Aha. So yeah. Sometimes I also use a forceps to catch the needle, but it's something wrong. What's the point of your?
Yeah, we discussed it during the anastomosis that touching at the same time with the needle holder and forceps may.
Oh, exactly. It means that the damage of the artery or vein. So you know that some big hole there or tear the artery. You are worried about that, right?
Yeah, damage of the needle. Would you like Darling to comment on this point?
Yeah, we try not to grab the needle with the forceps either. I think it's better just to grab it because you tend to grab it toward the end of the needle and can bend the tip of the needle or damage it. So we just try to use the needle holder in the middle of the needle and try not to hold on to the tip at all if you can avoid it.
And as a trainee question to the experts, what kind of suture you usually use? I mean, the size of the suture when you do the anastomosis to the distal crural or pedal bypasses?
So we pretty much use 6-0 in the popliteal and 7-0 in the tibials and 7-0 or 8-0 in the pedals or tarsals or plantars.
Okay, thank you.
The same with us. And in very small arteries, we use the same needle as in AV access fistulas, which is very small and very curved, so you can rotate easily the toe parts.
Thank you.
So I'm frequently use the EVA point needle for the calcified artery because the Japanese long-term diabetic patient or patient under dialysis has a severe calcification, but so EVA point needle is very good. But how about, what do you think?
Yeah, I agree, because if you don't have good needle, it's really awful to do a calcified crural anastomosis.
I often will use a cardiac cutting needle, which is a sharp tip, very useful in the calcified diabetic vessels, and a 7-0 typically for the more distal vessels, and even an 8-0 just to challenge the fellows on these distal plantar anastomoses.
Oh.
Oh.
Oh, beautiful.
All right, toe side score, please. Toe and number 5, the other side, also note type, please.
So, Dr. Komai, do you have any overall comments on this anastomosis?
Okay, thank you very much. I think the performance is very nice, and but I think it is a little bit difficulty in alignment, adjusting the vein to the arterial arterial hole.
Yeah, you mean that? Yeah, he cut the artery to be a little bit bigger. That's
yes. The alignment is a little bit difficult.
And Palma, so I would like to hear your comments also.
I really stress with the fellows and trainees to avoid grabbing with both sides of the forceps, either the artery or the vein. As I was always taught, it may precipitate apoptosis or future stenosis. So I appreciated his technique. I think he was very careful with the tissues. And sometimes I do put the forceps in to distend the vein, but I'm very careful not to over distend it.
Thank you. And Peter, any final comments on this, as you are our commentator?
Yes, thank you, Marit. As a final comment, I would just join to the Palma comment that he was very careful when grabbing the needle with the needle holder and taking care of about the surrounding tissues. And also what I noticed, he made a bit more oblique incision to the vein, but he managed at the end to trim it. Maybe that took him a bit time, but nevertheless, it was a good anastomosis.
Thank you.
Total point 82.33.
Thank you very much, and I think we can move to the next competitor.
Okay, so I would like to introduce our last finalist, Dr. Yohei Ichikawa. Oh, sorry. I would like to introduce Yohei Ichikawa, Dr. Yohei Ichikawa. So please start his video.
Hello, everyone. Thank you for giving me this opportunity to play in this final round. I'd like to introduce myself briefly. My name is Yohei Ichikawa. I'm from Kyorin University Hospital in Tokyo, Japan. I graduated from Kyorin University in 2014 and keep training to be an excellent surgeon. I'm very happy that such a many great vascular surgeons will grade my anastomotic skills. I'd like to do my best and enjoy the game. Thank you very much.
I am Masao Nurukawa, Professor of Cardiovascular Surgery of Kyorin University. It is great honor that Dr. Ichikawa attended the second Distal Bypass Olympic Games as a representative of Japan. He is a professional surgeon with excellent surgical technique and great enthusiasm for clinical research. By the way, we call an extraordinary surgeon Kokushi. Kokushi is spelled as nation's hand in Chinese characters, who cures patients and saves the nation. We believe that Dr. Ichikawa will become a Kokushi. I am convinced that he will make best performance in the second Distal Bypass Olympic Games. Please do the best that you can.
The Kitatama district of Western Tokyo is home to bustling shopping streets, popular tourist destinations, and establishments retaining the ambience of the ancient Musashino province. Here, one medical institution plays a pivotal role in community healthcare and provides advanced medical treatment for a wide area, including the neighboring wards of Setagaya and Suginami. This is Kyorin University Hospital.
So now you can start your procedure, anastomosis.
Okay, thank you.
So I would like to ask about how to, positioning, how to positioning the vein graft orifice. He used a kind of a clip, but in a clinical situation, what do you do in the clinical situation, Dr. Professor Darling, sir?
Sure. Sometimes if you have a little extra vein, what we will do, especially if you're going to a tibial, is actually staple it to the excess vein to the skin and pex it there, so that we can use that as a fulcrum as we put the stitches in, and then obviously remove that as you're bringing it down. Part of that depends on how deep the wound is and how and how much suture you have.
How about Dr. Benelmo? Same question.
So you mean do we use needle holder, or I didn't quite follow, sorry.
How to decide the position of the vein graft, he used that kind of clip.
How do you stabilize it? I think he's asking.
That's right.
Yeah, stabilize. Well, we quite often use the forceps inside the vein, just the heel part. We have needle holders, and some surgeons routinely use those. But I think it's important, of course, to visualize properly the vein heel part to use some kind of setup.
I'm using a very thin needle to put the vein graft on the skin or some part, then stabilize that.
That's very good idea.
How about Dr. Komai at the same? In terms of the same.
Yes. I just make the assistants to hold it. Don't move. And I like to put the forceps inside the vein, like a Helsinki group. Yes, it is very easily see it. The vein holder is we think it's difficult to sit at the same place. So we like to use the forceps.
So I would like to have your comments about vein bulb in a clinical situation. If you cut the vein, but you can see the bulb on the orifice of the vein, what do you do, Dr. Obara?
So thank you for question. It's totally up to the length of the vein graft. If you have enough the length of the vein graft, you can cut again the different side. But if the vein graft is just the size of the length, so we try to cut the vein, thin vein, very carefully.
You mean cut the bulb itself?
Yeah, it's there. So but it's totally up to the vein graft is enough length or not. So.
Okay, so is that the influence of the long-term durability, Dr. Darling? What do you think? If you have a bulb in the anastomosis site, near the anastomosis site, is that related to the long-term stenosis or not?
Well, if it's in the mid portion of the anastomosis, or as or Dr. Levy used to call it, the patch portion, where it's the widest, it's probably not important. If it's closer to the heel of the toe, I think it can be a problem.
So how about Dr. Shao? The bulb. Sometimes I'm concerned about the intimal hyperplasia near the bulb site, so in the middle term.
Yes, I think it can be difficult to predict, but I agree. Once you've trimmed the vein to the appropriate length and you open that and you see the valve, I would trim back the valve leaflet the best I can. Clearly, a thickened valve is concerning. There's some degree of hyperplasia of that vein. And I basically agree with Dr. Darling that I think in the middle of your hood of your anastomosis, it's less of an issue, but at the tip or the hub, it would be a problem.
Yeah, and just to add to that, I agree with Dr. Shah. Is sometimes we'll try to avoid the valve if we know when we're cutting the vein, and we'll leave it a little long, or in order to avoid it. But as you know, even in reverse veins or in situ veins, the restenosis tends to happen at valve sinuses.
Yeah.
Try to minimize the amount of valve leaflet that we leave if it's in the way.
I see. Thank you.
Okay, Dr. Zoe, Dr. Conte, please add your atomy score and a heel score, please.
I'd be interested in the commentators mentioning, we haven't discussed whether we're using reversed or non-reversed vein. We have not mentioned that, and use of a valvulotome, if there's a preference of how you lyse the valves, if you choose to not reverse the vein.
Yeah,
Anyone have a special preference, Dr. Zuma?
Yeah, so that there are many several RCT comparing reverse and in situ, no difference. But I think a decent error, so that the anastomosis size become very smaller, and then because of the diabetes, we need to do a pedal bypass, or at that time, reversed vein is a big mismatch, size mismatch in terms of the size of the vein, also that the thickness of the vein vessel. So I prefer that in situ or non-reverse vein graft. How about Dr. Benermo?
Yes, yeah, the question was, can you repeat it?
Yeah. So that what do you are you prefer the in situ or reverse or other?
Well, we routinely use nowadays reversed. We take the vein off, we turn, we with a tunnel, so we put it a little bit deep, and then we have wall. We cut the walls. When I started in the end of 90s as a trainee and graduated 2001, 21 years ago, in situ was used routinely an angioscope.
Oh yeah.
Anymore, we have changed the tactic.
Yeah. I saw your Helsinki's paper. So residual valves still there, many percentage, right?
Yeah.
Using the valve cutter, but still residual valve there. But
yeah, go ahead.
How about the thickness of the vein? They're very thick, in terms of the distal anastomotic site. Small artery, but very thick vein. Is that no problem when you use a reversed vein graft? I'm sorry, my English is not enough to
just regarding the thickness of the vein, Merritt, perhaps the more proximal greater saphenous vein at the origin is thicker. And then when we reverse that, is that an issue at the distal anastomosis?
Yeah, that's right.
Yeah, we tend to use in situ, especially in the more distal tibial vessels, if you can, or an orthograde, just because of vein size mismatch.
Yeah, that's right.
And use a Mills valvulotome. If they were trying to do a closed in situ, we've now gone to the lamate, but there's always some issues with a closed in situ and valvula, but there are also issues with an open in situ with wound complications. So I think you have to choose.
Yeah, very important. Yeah. So
we're just writing up our experience, I think, with 6,000 in situs, but
huge.
Dr. Conte, initial size score, please.
So and also so other many commentators mentioned about grasp of the vein graft, like this competitor. So what do you think about the grasp of the vein graft? Just advantageous or no? Is there influence on the?
Yeah, we just try to grab the adventitia if we can.
Yeah, that's right.
And try to evert the anastomosis so you don't have the adventitia inside the anastomosis. So you want to have intima to intima.
Yeah, that's right. So relating this answer that Dr. Peter, so I think what do you keep in mind during anastomosis, especially for the long-term durability. So we should do a long-term durable revascularization when use good quality vein.
You mean about the technical points when suturing the distal anastomosis?
Concept of the
the concept, yeah. So thank you for your question. Very good one. So we always tend to suture the distal anastomosis at the place or the artery where at least it has the connection with the foot and without any significant distal stenosis. We always, of course, tend to move it higher. I mean, if we do the vein bypass, to do it on an infrapopliteal segment or P3 segment of a popliteal artery, if it's the distal tree has at least one artery that has a connection with the foot. But if that's not the case, we do it more distally. Again, regarding the post-operative course, maybe we didn't touch on this, but we also, I mean, what is also advisable to do is control duplex or angiography, which I think is very important because in a lot of circumstances we will see something that you do not like, either with a twisting of the bypass, tunneling in the wrong way, doing the proximal distal in a bad way, so you have to correct this. And of course, the post-operative education is very important. I think if you have only one crural vessel that has a connection with the foot, it is important to adjust anticoagulation therapy as well.
Thank you. So you mentioned about how to complete the operation. So are you doing a completion angio or measuring flow, graft flow, or just watching?
Well, that's a good question. So yeah, if the patient has a palpable pedal pulses, we don't do anything. But we used to do and one of my mentors used to do a lot of flowmetries. So we're fond of flowmetries, and nowadays we're starting doing angiography if there is suspicious that we did something wrong, that something is not happening and going well with the procedure itself. So yeah, we don't have a quite standardized fashion we do it, but that is how we approach it. But I would like to see to hear the comments from the others as well, because I think it's very important.
Lastly, I would like to ask you about this event itself for the young vascular surgeon. So what is the most important impact on your vision as a young vascular surgeon to watching this kind of event?
You mean about this event, about the distal bypass competition?
Yeah, that's right. Yeah.
Yeah, I think it's a very good one. The competition is something that the trainees like very much, and we are looking forward because we like to show that we are better than others. That's simply the nature of the trainees. So I think it is a good way to attract a lot of young people because a lot of them are quite shy and don't want to expose themselves a lot. So doing this is very good and very important in promoting still the open surgical skills, as you mentioned, in the light of the latest best CLI trial findings. So I think it's a good way to continue, and organizing, of course, ideally on-site event would be great, but yeah, I think it's a good one, and congratulations.
Thank you very much. Your very precious opinion. Dr. Yohei Ichikawa, thank you very much for your nice technique.
Yes, thank you.
Very beautiful inside appearance, I think. Starting.
I could enjoy it.
Oh,
yeah,
that's good. Actually, Dr. Ichikawa was studying in my department for 1 year, right?
Yeah.
Yeah. Okay. So I think I would like to have a comment from judges. At first, Dr. Conte, please give us a comment as a judge.
Yeah, thank you, Dr. Zuma. This is a very fun and I think a useful competition to promote technical skill in distal bypass surgery, which I think is increasingly important because of the changes in practice over time and also the growth of our diabetes population. So very important to do. I also found it very interesting to see the different techniques people are obviously being taught and how they manage the heel and the toe and the handling of the graft. And I would say what you talked about at the very end is so important. Regardless of which technique you use, you must be confident at the end of the procedure that it's technically perfect. So you have to do some imaging. I prefer to use both ultrasound and angio at the end of the case to get a full evaluation of the graft. I think all the trainees did a great job. I think it's hard to do this by yourself. Sometimes you have to do it by yourself, but more often we're assisting each other.
That's right.
And providing the support for the graft and making sure the sutures are not tangling. The only other comment I would make is I noticed that many of the competitors prefer to do almost the entire anastomosis or most of it backhanded. I make a strong attempt to switch over so that you can do some part of it forehand. It's just an easier technique. Once you come around the toe, take the other suture and then go towards yourself. That's usually how I finish.
Yeah, thank you very much for your precious comment. And very, it's a very important for other world-class, world-famous vascular surgeons comment. Thank you. So, Dr. Katsuyuki Hoshino, could you give us a comment as a judge?
Yes, I'm very excited and enjoy the competition, and I have some comments for each competitors. The third competitor, Dr. Ika. The U-shaped thread ring at the here is very interesting. It's my it's a first time for me, and that is a type of parachute suture, but the forceps is used to widen the vein to confirm the lumen of the vein. It's very good, and I like it. But it resulted in artery and vein mismatch later on. So that's very unfortunately. And the last competitor, Dr. Kikuchi, he used his left hand remarkably well. That's very different from other competitors. That's my impression.
You mean that the left hand contributes to make a good surgical field, right?
Yeah. So his forceps with the left hand don't hold the artery wall, but push the vein and only push the artery to clarify the internal lumen of the artery. That's very impressive.
Nice, thank you very much. Also important comment. So Dr. Konkar, thank you for your precious time. Please give us a comment.
Thank you. I enjoyed actually the whole competition. My name is Igor Končar. I'm a vascular surgeon from Belgrade, Serbia, and I'm chair of the ESVS Academy. It's a committee in the European Society that is organizing hands-on workshops. So we really support the whole idea, and all our workshops, about 60 during the year, are hands-on. And especially the technique of vascular anastomosis is one of the basic techniques that I think is supporting the trainees from the very beginning to practice. And it's not the evidence-based technique, so it's more how I do it. So we could see the difference in between different schools of doing anastomosis. Here, the 4 schools, all anastomotic techniques were a little bit different. And as we heard from the commentators, there are differences in how everyone do it. And as previously said, it's important at the end that it works well. And what is also, I think, important is that we could see that the winner probably is the one who did all the steps in the procedure equally good. And I think this is one of the messages, to our colleagues and trainees, that you should be happy if you do very well arteriotomy, because there is a long way until the end. So you have to do all the steps very well. And then I think this is an operation in a small, so the same is for our procedures. We have to do the procedures equally, every step equally good.
Yeah. Thank you.
And I really enjoyed the whole commentators, and I'm really the whole discussion was very interesting. And thank you for this opportunity.
Yeah, the discussion between the world-class vascular surgeons are very, interesting, I think, for the audience. So how about Dr. Akio Kodama?
Thank you. I enjoyed to see each surgeon's skills, and indeed this event is one of the games, but this competition could be very useful for young trainee. So hopefully this event will become more attractive or more common for young vascular surgeon all over the world. And if I were a young surgeon, I would participate in this event, but I was too old. Thank you.
Thank you. So lastly, Dr. Wei Zhou, please give us a comment. Thank you for your precious time.
Sure. So I really enjoy the events. I think all the competitors did a wonderful job, really showcasing the techniques at each center in Japan, Helsinki, and Albany. And we really realized how we do bypass differently, just technically. And I echo Dr. County, we learn from each other, and this is really a good event to learn from each other across the globe. I also enjoy the comments, the camaraderie and the discussions on what is the best technique to perfect our anastomosis, even though this is only one part of the procedure. I think this event in general really highlighted collaborations and if around really for all vascular surgeons, hopefully set an example for the younger surgeons as for us to collaborate in the future.
Thank you. Thank you. Important comment for the future. So now we heard every judge's comment. Then maybe open the final result of competitors. Dr. Park, can you show us the? Oh, yeah. We need to see this video before the open the result. So you can see the very high level competition, and but unfortunately we need to select color of the medal. So I need to, I wanted to send a gold medal for all to competitor, but result is like this. So at first, Dr. Yuki Kinoshita and Dr. Amanda Kistler got a bronze medal. This time, unfortunately, but you did a good job, I think. Dr. Kinoshita?
Yes.
Oh, yeah, you did a good job. What do you feel, and did you enjoy?
Yes, I enjoy, but the result is, I'm sorry.
No, but it's your top. Your order of the competition is still maybe not maybe lucky.
I think it doesn't matter. It's just an excuse.
I choose a lot. Amidakuji, you know. So yeah, but I think you did a good job. So we will send you a bronze medal, not medal, but you can see that prize later. So thank you very much for your contribution.
Thank you.
Yeah. Dr. Amanda Kistler. Dr.
Yes,
Amanda.
hello.
Oh yeah. Unfortunately, your image resolution maybe unfortunate, very unfortunate. But
Yes,
I
unfortunately,
think.
I apologize for the technical issues on my side.
Oh yeah. So I think this event should be very the resolution influence the result. But I think you're doing a very good job, and then bronze medal go to you. So thank you very much.
Thank you so much.
Time, and future success. Yeah, thank you.
Thank you.
And also your video is very nice. Yeah, your video that's encouraging by many surgeons. We enjoyed your video a lot. Thank you. Now, so silver medal goes to Dr. Ika Jevin. Dr. Ika.
Left it? Yeah. Already logged out.
Really?
Found it.
Oh,
no, I'm.
Oh, yeah. Congratulations. You got your silver medal.
Thank you very much.
How do you? Did you enjoy? Or?
Yes, I did. Thank you for the opportunity. Yes, it was exciting and educating.
Mm-hmm. Yeah, thank you very much. Your precious time, and I think I had it's some difficulty. There was a difficulty to send a simulator to the Helsinki, and many trouble. But you overcome that trouble and then get a silver medal. So thank you very much for your contribution. And good.
Thank you.
Thank you. Now a gold medal go to the Dr. Yohei Chikawa. Congratulations. You're muting. Please give us a comment.
Sorry, I was mute. Thank you, Dr. Azuma.
Yeah, that's okay.
I'm very honored to receive this award. I think it was very tough competition. And first of all, I'm very grateful to Professor Azuma for training me in 2020. Thank you. And I would like to thank all members of Kyorin University, JSBS, and my family for supporting me. I'm encouraged by this result and will keep on my training further for the benefit of my patients. I hope this will be an opportunity to continue the relationship with young surgeons from all over the world. Please come and visit Kyorin University. If you like, I would attend. Thank you very much.
Thank you. So please continue to encourage young vascular surgeons.
Yes, thank you very much.
Thank you. So now we need to close this session, but before closing, I would like to ask about closing remarks by Professor Parma Shaw.
Thank you so much, Dr. Zuma. I want to say this has been just an incredible event. I've been so excited in the preparation of this, and I'm so enthusiastic about the collaboration between the different societies. It's just it's a dream. It's a dream really to bring everybody together at all levels, the professors, the mid-year, the mid-career, and the trainees, and in a parallel way, unite training and education across the globe in vascular surgery. And I think this aspect of the distal bypass competition, which you've so strongly championed, is a wonderful way to do this, particularly, again, you mentioned in the light of the best CLI trial results. It's more important than ever that we provide excellent education for our trainees. And I think I can speak for the leadership of the World Federation, and I think the counselors, several of which are on this call right now, that we enthusiastically embrace the future collaboration of the different societies. This was a pilot study where the SVS and the ESVS joined your group, and thank you very much for sponsoring that. And we've really enjoyed it. So we will plan to expand this and discuss this further at our next council meeting at the VEITH. Thank you so much.
Thank you very much. You're very. Thank you very much. We are looking forward to popularize under this event, especially that so that the vascular surgery is not popular in the country, but the WFS has a great role to encourage those countries and vascular surgeons. Thank you very much. So now we need to close this international important event, and then we are very happy to work with all of you, and then very happy to work with very famous vascular surgeons and also young leaders. And also I would like to thank you, Dr. Park, EBM, to solve the difficulty and the very complex procedures. Dr. Park?
Yes, everybody, thank you for joining us. Okay, so I found a lot of technical issues, but maybe we can overcome. So looking forward to work with you. So next time, thank you so much.
So thank you very much for everyone. Thank you very much. Bye-bye.
Thank you very much. Great to see all of you. Bye-bye.
Great job.
Thank you very much.
Thank you.
Very great. Thank you.
Thank you. Thank you.
you.